In this video, we present surgical management of perianal fistula using an ovine forestomach matrix implant. Author Joshua Wolf is a consultant for Aroa Biosurgery. There is currently no optimal technique for the surgical treatment of perianal fistula. Invasive surgical techniques have higher efficacy, but also higher risk, and less invasive techniques with lower risk have poor efficacy. Examples of higher efficacy procedures with higher risk include lift and flap, and examples of low efficacy procedures with lower risk include fibrin glue injection or traditional fistula plugs. The optimal procedure has low risk and high efficacy, a balance that we believe can be achieved through the use of ovine forestomach matrix as a biologic perianal fistula implant, and we will demonstrate this technique. This is a case of a 23-year-old male patient with HIV who presented with a transsphincteric perianal fistula. Of note, his HIV was well controlled with an undetectable viral load and a CD4 count of 600. He had undergone previous incision and drainage for a perianal abscess and subsequent ceton placement, and following this was observed for 12 weeks in order to allow the fistula to cool down. After positioning the patient in left lateral decubitus, the operative area is prepped and draped, and the fistula is exposed, visible here in the right posterior perianal soft tissue, just adjacent to the midline. A circumferential perianal block is applied with a mixture of lidocaine and bupivacaine. The fistula tract is then aggressively debrided with a curette to ensure complete removal of epithelial tissue lining the lumen of the fistula. The length of the tract is estimated. The biologic matrix is hydrated with sterile saline and measured on the back table. It is then rolled in a cylindrical configuration in preparation for insertion into the fistula tract. An absorbable suture is placed through one end of the implant, secured and tied to the ceton. The ceton is then cut and used as leverage to pass the implant through the tract. Often this requires a push-pull technique with insertion into the external opening of the fistula using forceps. The implant is now properly in place with 5 millimeters of overhang externally and internally, and now ready to be sutured in place. This is done by placing 2 ovicral sutures in a figure of 8 manner through the anal wall and through the implant, thereby obliterating the internal opening. Generally, 2 or 3 figure of 8 sutures are required. The external opening is not closed, but rather simple interrupted vicral sutures are placed through the implant and into one side of the external opening wall. This allows for drainage to pass through while the fistula is healing. The final configuration is shown here. This is an outpatient procedure, and following surgery the patient was discharged home. He was seen for close follow-up every 2 weeks until complete healing at 6 weeks postoperatively. These images show the progression of healing as the implant transitions into a granulating wound and ultimately into a fully epithelialized closed scar. This technique has several advantages. First, it has minimal impact to surrounding tissue and therefore low risk of sphincter injury, and all options remain available for future fistula closure in cases of failure. It is easy to learn and has a short learning curve, and has low cost relative to other biologic matrices. And in our pilot results presented at last year's ASCRS, we noted 78% successful healing at 8 weeks and 0% recurrence at last follow-up. This technique is the subject of ongoing investigation at our institution.